Hello, this is Dr. Anju Singh recording for exercise 23, the general senses from Allen and Harper 6th edition Laboratory Manual for Anatomy and Physiology. So I just created this chart to give an overview of different sensory receptors. So in the last few exercises, we've talked about reflex arcs, spinal nerves, somatic reflexes, and autonomic reflexes. All of these reflexes start with a sensory receptor. We have numerous different types of sensory receptors in the body. They can generally be categorized into two categories. One is the general sensory receptors and the special sensory receptors. As the name suggests, the special sensory receptors belong to special senses like the photoreceptors in the eyes, the receptors in the inner ears, receptors in the nasal mucosa that help us smell, receptors in the tongue that make up our taste buds. Those are the special sensory receptors. The general sensory receptors are further subdivided into somatic and visceral receptors. The somatic receptors are the ones that are usually present on the skin and the muscles. And the visceral receptors, as the name suggests, are present on the internal viscera of the human body. All right, and the general function of the sensory receptors basically is that they sense the information in the environment, and they bring that information from the external environment and convey it either to the spinal cord or up to the central nervous system. The sensory receptors are structurally divided into two different types. We have the free nerve endings, which are the dendrites of the sensory nerves themselves, and they convey to the brain the general sensations of pain, temperature, tickling, itching, and to some extent touch sensations. And then we have the encapsulated nerve endings that are also dendrites of sensory neurons that are enclosed within with a connective tissue that the capsule, and they convey the general sensation of touch and pressure to the brain. Some receptors of special sense organs are receptor cells that then synapse with the sensory neuron. All right, so there's a difference. The free nerve endings and encapsulated nerve endings, these are the dendrites of the sensory neuron themselves, whereas sensory receptors, these are receptor cells and they synapse with the sensory neuron. They are not dendrites of the sensory neuron themselves. So make sure you remember the difference between these two. So here we come to figure 23.1, and what I've done is not only labeled it, but I've also taken the information from table 23.1 that tells us the different types of receptors and what they do. So this here is a cross-section through the skin showing different sensory receptors. So just to get orientation, right on top here we have the epidermis, and then we have the dermis and the subcutaneous layer, which usually has adipose tissue in it, and then we have hair follicles in our skin. So as we can see here, we have some nerve endings. These nerve endings are themselves dendrites of the sensory neuron. Nerve endings, the different kind of receptors we have, we'll just go by numbers. So number 1 here, this is called type 1 cutaneous mechanoreceptor, also known as Merkel's discs. And they are mainly responsible for touch and pressure sensation. These are free nerve endings. And they are usually associated, they're usually found in the stratum basal layer of the epidermis. Number 2 is the corpuscle of touch, or also known as Meissner's corpuscle. And they are also responsible for touch and pressure. And these are also sort of free nerve endings, but you can see structurally they're slightly different. The Meissner's corpuscles are encapsulated nerve endings. These are not free nerve endings, these are encapsulated nerve endings, and they are found in the dermal papillae of hairless skin. Number 3 is the type 2 cutaneous mechanoreceptors, also known as Ruffini's corpuscles, and they are responsible for the stretching sensation of digits and the limbs. And these are found in the dermis, the ligaments, and the tendons. These are also encapsulated nerve endings. Type 4 is hair root plexus. This is again found in the, as the name suggests, in the hair roots. They surround the hair follicle. These are free nerve endings and responsible for, if just the hair are touched and not the skin, we can still feel it, and that's because of these nerve endings. Number 5 is the laminated corpuscle, also known as Pacinian's corpuscles. And these are found in the subcutaneous and submucosal tissue, in the joints, in the tendons, and in the muscles. And these are also responsible for touch and pressure sensation. So as you can see, we've got numerous receptors whose function sort of overlaps. So touch receptors, or the touch sensation, is perceived by type 1 cutaneous mechanoreceptors, by the Meissner's corpuscles, by the hair root plexus, and also by the Pacinian corpuscles. In addition to these, we also have free nerve endings that are responsible for warm and cold sensation. We don't just have one kind of receptor for temperature. We have two different sets of receptors. So warm receptors are found in the dermis. These are again free nerve endings, and the warm receptors can sense temperatures between about 32 to 48 degrees Celsius, which is about 90 to 118 degrees Fahrenheit. And cold receptors are found in the stratum basale of the epidermis. These are also free nerve endings, but their activation, if you will, their stimulation is most sensitive between the ranges of 10 to 40 degrees Celsius, which is about 50 to 105 degrees Fahrenheit. So as you can see, there's a little bit of overlap between their ranges, but we do have separate set of receptors for warm temperatures and a separate set of receptors for cold temperatures. And then we have pain receptors. They're also known as nociceptors. And these are found in almost every tissue of the body. These are again free nerve endings, and they are found almost in every tissue of the body. There are very few tissues in the body that are missing pain perception. For example, the cervix of the uterus. Just the cervix of the uterus, not the entire body of the uterus and not other parts of the female reproductive system, but just the cervix of the uterus. And women who've had a gynecological exam, and pap smear may be able to relate with this, is when they do go for an exam, the doctor usually holds the cervix with a toothed forceps. If you try and hold the skin with that same toothed forceps, with the force that the doctor holds the cervix, that can be an extremely painful experience. But women undergoing a pap smear do not feel that pain, and that's because the cervix lacks the pain receptors. And then we have the muscle spindle receptors. Again, as the name indicates, they are found in most skeletal muscles. These are encapsulated nerve endings, and they are responsible for sensing changes in the muscle length. And finally, we have the tendon organs, which are found in junction of tendons and muscles. And these are also encapsulated nerve endings, and they respond to change in joint position and in movement. All right, so now that we've kind of sort of covered most of the general sensory receptors, we'll take a quick look at how these receptors work. So here we have some of the most common, or actually just two of the most common sensory pathways in the body. All right, now when we did the reflex, if you recall, we did say that there were some reflexes. In the reflex arc, you may have as few as just 2 neurons. You need a sensory neuron that can synapse with the motor neuron, and then you have the motor neuron, and that's the end of the reflex arc. But most of the sensations that we can consciously perceive, like touch, pressure, pain, temperature, even some proprioception, that is movement and position of limbs, all of these sensations, they are actually polysynaptic, which means they involve numerous synapses. So generally, these sensations have sensory pathways that consist of chains of 3 neurons. So they call first order, second order, and third order neuron. The first order neuron is the sensory neuron that is located in the peripheral nervous system, and it synapses with the second order neuron. So the sensory neuron, the one that has its cell body in the posterior dorsal root, which is a unipolar neuron. Does that ring a bell? We talked about that a few exercises ago. All right, so the cell body is in the posterior ganglion. Its dendrites are the ones that make up the sensory receptor in the peripheral organ, and its axon then goes into the spinal cord. And that axon then relays onto an interneuron. That interneuron is your second order neuron. So in the anterolateral or the spinothalamic pathway, the interneuron crosses over to the opposite side and ascends up the spinal cord in 2 different tracks. It has the anterior white column and the lateral white column. But because as they go up, once they reach the medulla and the midbrain, they actually form one track. They're also known as the anterolateral or the spinothalamic tract. And this tract then finally relays in the thalamus. The second order neuron relays or synapses with the third order neuron in the thalamus. The third order neuron goes ahead and relays in the postcentral gyrus or the primary somatosensory cortex of the brain. That's where then that information is processed. It may further synapse with an associating neuron and other different kind of neurons that we talked about to analyze and interpret the stimulus that was perceived to come up with the motor response. So that was the anterolateral or the spinothalamic pathway. The other most common pathway is the posterior column tract, in which case the dorsal root ganglion relays onto the posterior white column, and the first order neuron actually goes up to the medulla. And in the medulla, that's where it synapses with the second order neuron. The second order neuron then crosses over to the opposite side, goes up into the midbrain, and relays in the thalamus. And then the third order neuron goes from the thalamus to the postcentral gyrus or the somatosensory cortex. All right, so that's the difference between the anterolateral and the posterior column tract. Posterior column tract lesions can be seen in demyelinating disorders, in spinal injuries, in spinal tumors, and then because of the difference in where the first and second order neurons synapse and where they cross over, you can imagine how the clinical features can vary. So depending on how the patient manifests, like whether they have ipsilateral paresthesia or we can tell what level the damage is on. Now, few sensations do not reach the cerebral cortex. These would be like proprioception and information from the visceral sensory receptors. So these pathways do not contain a third order neuron. And you can think about it, you can't consciously control your visceral responses sometimes. So that would make sense. So here I just want to go through the lab activity in your book on page 358. So basically what they've asked you to do is, again, this is a good recap of something we've done earlier in exercise 16, the nervous tissue. So they've asked, are sensory neurons from general sensory receptors, are they unipolar, bipolar, or multipolar? Sensory neurons will be unipolar neurons. Where are the cell bodies of the sensory neurons or the first order neurons located? So the cell bodies are located in the dorsal root ganglion or the posterior root ganglion. Where are the axon terminals located? The axon terminals will be in the sensory organ, right? Sorry, not the axon terminal. The axon terminals will be located in the spinal cord. The dendrites are located in the sensory organ. And then where are the cell bodies of the second order neuron located? The cell bodies will be located in the spinal cord. Where are the axon terminals of the second order neuron located? That'll be in the thalamus. And where are the cell bodies of the third order neuron located? That'll be in the thalamus. Where are the axon terminals located of the third order neuron? That'll be in the postcentral gyrus of the primary somatosensory cortex. Where is the posterior column tract cross to the opposite side? That's in the medulla oblongata. And where does the anterolateral or the spinothalamic pathway cross to the opposite side? That'll be at the same level of the spinal cord, so in the spinal cord itself. All right, and these are just two examples of the numerous pathways we have in the body. So here, moving on, a few important concepts when it comes to general senses or the somatic senses, if you will. All different parts of a body are not equally sensitive. All right. Some parts of the body are more sensitive than others. And one way we measure tactile sensitivity is if you can differentiate between 2 points of stimulus. So for example, if you were to close your eyes and somebody else was to touch a certain part of your body with two, say, pinpoints very, very close to each other, would you be able to differentiate those 2 points as two separate stimuli, or would it feel like one stimulus? If you were to take those 2 pins and say put it on your lips or your cheek, the chances are they would be very, very close together when you will be able to perceive that they're 2 separate pins. However, if it's put, say, on the back of your leg or on your back, they would have to be moved further apart for you to be able to appreciate that they're 2 separate pins. So in order to check for tactile sensitivity, that's how we do it. So for early paresthesia, for some sort of neuropathies and other neurological disorders, if a physician wants to check for loss of touch sensation, that's how they do it. They would ask the patient to close their eyes, and they would have 2 tiny sort of pinpoints close to each other and touch the patient and ask the patient to say if the patient can feel 1 pin or 2 pins. And usually you start off with it being just 1 pin sensation, and then you move the pins further and further apart till the patient is able to identify that they're 2 separate locations. So in sensitive parts of your body, those 2 pins will be a lot closer when you are able to perceive them as 2 separate points. In less sensitive parts of the body, they have to be further apart. And we're able to distinguish that in sensitive parts because we have more nerve endings close together in those parts. So the density, the number of nerves per square inch of that organ, or whether it's the skin of the lips and the cheek or skin in a different part of the body, the number of nerves per square area of the organ is more in sensitive organs. And that's also known as the touch receptor density. And these receptors occupy larger areas on the primary somatosensory cortex, because all of these neurons then relay in the somatosensory cortex. So the more sensitive parts of the body are represented in a larger area. So it's directly proportional. The size of the somatosensory cortex area receiving the sensory information from that specific body area is directly proportional to the cutaneous receptor density. All right, so sensitive areas have more free nerve endings. They are more, they have a larger touch receptor density, and they will have a larger representation on the somatosensory cortex. And the 2-point discrimination test is a clinical way to diagnose that. So that was tactile sensitivity. And sort of a similar test is done even when we measure visual acuity. And I know that's a sensory receptor, and we can talk about that again when we talk about special senses. But when you go to a doctor and you're doing your 20/20 vision test, basically what you're testing when a patient's vision is being tested is what size does a letter have to be? How far apart do 2 lines or dots need to be for a patient to be able to perceive that they're two separate dots and not one. So basically, even a visual acuity test is a sort of a sensitivity test. It's a visual sensitivity test. The next concept we want to touch upon before we end this chapter is adaptation. So our receptors, when they are stimulated, they secrete neurotransmitters. All right. If the stimulus is constant, either over time or intensity or frequency, the nerves can get fatigued, if you will. And their baseline firing potential, if you will, can reset at a different level. And that is known as adaptation. All right. So a good example of that would be if you were to dip your hands in warm water for a while. So initially, when you first, or when you step into a hot water tub, into a hot water bath, when you first step into it, the water feels really, really warm. But after you've sat in it for a minute or two, the water doesn't feel so warm because you've adapted to it, you've adjusted to it, your receptors have adjusted to that. Vice versa, when you first put your hand into the cold water, when you first go into the swimming pool, say after Memorial Day weekend, the first time you enter into the water, it feels really, really cold. But once you've spent a couple of minutes in the water, you don't feel that cold anymore. That's your sensory receptors adapting to the environment. All right, and all our receptors have that adaptation. And I'll go back to the example of sensory receptors. I know we're not talking about sensory receptors here, but they too can adapt. For example, if you've been out in daylight and you walk into a dark movie theater, you're not able to see anything. That's because your lights have been used to the bright light and they can't see in the dark. But if you've been in the dark room for a while, then you're able to start seeing things that you weren't initially able to see. That's because your light underwent dark adaptation. They adapted to the dim light. All right, and when you're adapted to the dim light, when you suddenly walk out from a movie theater after being in it for a decent amount of time into the bright daylight, you suddenly have to squeeze your eyes and shut them because a regular daylight is too bright for you, because your eyes were dark adapted and they have become very sensitive to light. But again, if you've been out for a couple of minutes, you adjust to that, your receptors adapt to that. And so all receptors within normal range are capable of adapting. All right, and the final concept we want to touch upon on this is the concept of referred pain. So for example, you must have heard that one sign of heart attack is pain in the left arm and the chest, left side of the chest. Patients don't always say, my heart is hurting. They usually will manifest with symptoms like pain in the left side of the chest, and the pain can be, the description of the pain can be different. Some will say it's a constricting pain. Some will say it's like someone's put a boulder on their chest and they're not able to breathe. They're like almost suffocating. Some will say it's a sharp shooting pain. Some will say it's a burning pain. Some will say it's a pin pricking kind of pain. And some will say the pain is shooting down the left arm. So the quality of the pain can differ in people. So how does heart attack show up as referred pain? That's because the visceral receptors from the heart are relaying in the same place in the brain as the sensory receptors from the left arm and the left side of the chest. And when the brain perceives these two sensations coming from the heart, it thinks it's coming from the left arm. And that's why the patient believes they are having pain in the left arm. Same thing for, say, appendicitis. Appendicitis pain may initially start as an epigastric pain. And again, because that's the dermatomes, the neurons that supply the appendix also supply the skin in those areas where the referred pain occurs. All right, so initially it is a pain that originates in the visceral organ but is perceived in the skin that is innervated by the same spinal segment. All right. right? And that is called referred pain. And in clinics, that's how we diagnose. Patients cannot say my appendix is hurting, or my stomach per se is hurting, or my heart is hurting. We cannot consciously feel our visceral organs, but the spinal level at which they relay, the skin dermatomes that also relay on the same spinal derm, we feel referred pain to that dermatome, and that's how we know which organ the pathology lies in. So as usual, I want to end this chapter by encouraging you to review the knowledge at the back of the book. Try and do the exercise in the back of the book and answer the questions. And if you're able to answer these questions, you are in good position to answer questions on the test. All right, thank you.